You know, like, when I do exam reviews, why they seem a little choppy. I'm not one of those instructors who will have a test that's been, where was I? Oh, this would be a good one for you. And we've actually kind of talked about this, let me see my stuff. No, oh gosh, ATI, okay, I know what you want. What are your treatments going to be for DKA and HHS? I put them all in one thing.
It's gonna be IV fluids.
IV fluids first. Now let's look at the why. Why the IV fluids first?
They're dehydrated.
Yeah, exactly. Because have they been polyurine? Both of them, especially HHS. Good. And what else?
Hypervolumic shock.
Yeah, so they could have gone into hypervolemia. So we're doing what we call actual fluid resuscitation. It's actually happening. So what other treatments? Insulin. Who is primarily going to be getting the insulin? DKA. And for Inflex World, what form is it going to become in? Drip. Oh, you guys are good. Yes. Now, what is the theoretic reason insulin will be given to DKA in a drip?
It's gonna prevent them to go into acidosis.
That's it. That's it. Because once you give them that key, is it gonna start opening up the cells, letting glucose in, so the body at that point says, oh, we have our energy source. I'm gonna stop breaking down fatty acids. That is really good. Fluid resuscitation, insulin for DKA, and those are the two primary things, right? Those are the two primary. Oxygen, no, because people say with Kuzmals. So those are the two major concepts. Oh, I was gonna ask you, what is the other reason that we're giving the IV fluids?
For electrolyte imbalance.
To dilute the glucose level. And speaking of electrolytes, oh, that's another thing. Potassium. Let's talk about potassium. Might you have to give them some increments? Or even PO? Yes, let's talk about that. Are you going to be putting these patients on a monitor? Now, why on earth would you do that? Because of the hypokalemia. But guess what? So I'm looking at your cards. They're not wrong when they say hyperkalemia. Let's talk about hyperkalemia, especially in acidosis. Why does a patient in acidosis have hyperkalemia? Because during acidosis, K gets released from the cell. So guess what you see initially for DKA? Hyperkalemia. Does it last long? No. And why doesn't it last long? Yes, you could dump some K because of the polyuria. What's the second thing?
Insulin opens the keys when it goes back.
Holy moly. 100% correct. When they start getting that insulin is going to drive the potassium back into the cell. That was really, really good. I swear I'm gonna get gold stars. That was great. Did that make sense to everybody? But ultimately, most of your test questions are going to say hypokalemia. And then a lot of that leads you to say, to intervene by putting them on the monitor. Those are the questions that I see all the time. And can you replace it? Yeah, you can give PO, you can give increments depending on the level of the, yeah. But initially they're gonna be hyperkalemic, because acidosis dumps it right to the serum, then they start peeing it out, and then the insulin will further drive it back into the cell. Remember hyperkalemia, that's one of the treatments. Remember insulin, bicarb, what was the other ones? Dumping it with some Lasix. Yeah, so you have different things, K-oxalate, different things. This is not on your test, but it may be on your CMS. we're pretty much done with your review here. So, if somebody asked me this, who asked me this question? I can't remember. So, your IV is initially going to be 0.9% saline, some sort of isotonic. But especially in that DKA patient who has received the insulin drip, now what are you worried about? Hypoglycemia. How are you gonna prevent the hypoglycemia?
Stop when your blood sugar gets to a certain point.
To a certain point. This is a potential test question in your future. There's a certain number that they reach that something happens. So what is it? 250. Oh, very good. Now, what's your IV fluid gonna be? After their blood pressure is, resuscitated, so, what is it?
Hypertonic.
Yeah. So what percentage of dextrose is gonna be in that IV? 5%. That's so good. And they can actually do a number of things, but it has to be a 5% dextrose solution, large volume. It can be 5%, and then it could be a half normal saline. It could be 20 milliequivalents of potassium, depending on what their kilo, see where I'm going? They might even be doing two things at the same time, making sure that they don't go glycemic. And number two, to replenish some of the K that they have lost. But really, the premise behind that would be the 250. So they have specific parameters, which is very smart. All right, who's next? Josephine, what's a pheochromocytoma? I know you know this.
I know this.
It's an oma, isn't it? Is oma bad? We don't like omas.
Oma is cancer.
Yeah. She's right.
You say a feel?
I can't remember.
It's a tuba. So where's this tumor?
I don't remember.
Well, let's do it. So who wants to take it away? It's an adrenal tumor. Could it be on both sides or just one? Either way, yep. It's an adrenal tumor. And Donna said the 5 H's. So what are the 5 H's? Headache, hypertension, hyperhidrosis, hypermetabolic state, hyperglycemia. Good job. And can we treat them initially symptomatically? Yep. So they're gonna be probably tachycardia. Gee, I would love to probably give them a beta blocker, because to take care of the tachycardia and the hypertension at the same time. And hyperglycemia can give them maybe a little bit of insulin, and then what's the other ones? You can't take care of the hypermetabolic.
Adrenalectomy.
That's it. So whatever you can treat as a nurse symptomatically, you treat it.
So is it 5H and T, right?
Put on the test, it's gonna be 5 H's.
Okay.
That's what you see in the literature is 5 H. It helps to define it, but then when you think logically, when you have a tumor in any endocrine gland, is it overexpression? Yeah. And what are we overexpressing here? Lots of things. How about cortisol?
Yes.
How about aldosterone? And catecholamine. Because if that tumor gets to the medulla where those cats live, you're gonna have some, maybe even add arrhythmias, palpitate, see where I'm going? But they like to keep it nice and clean. So let's do the 5 H's. Is it going to be another select all that apply? It really is. Okay, let's get up to some Addison's disease. Where are we? We sort of, okay, Mary, what do you know about Addison's disease?
It is low ACTH.
Ooh, good.
You can have an Addisonian crisis. It is hyponatremia and hyperkalemia. is due to a decrease in serum sodium.
Yeah,
It has, we have lack of cortisol and lack of aldosterone.
is primarily the thing. Can you have also lack of catecholamines?
Yes.
Yeah, I know I had this PowerPoint presentation from Lippincott, and it had cats too. So let's look at that. She's absolutely 100% correct. Why are they hyponatrated? Because of which hormone or lack of those? Good job, because of lack of aldosterone, salts and aldosterone. And is hypotension also caused by a lack of aldosterone? Yeah, because of the lack of volume, right? Water. Mhm. And then why the hypoglycemia? Lack of corticosteroids, of cortisol, right? See if something's low, what's gonna be the profound effect or effect. Now, if you have low catecholamines, what's that gonna do to your vessels? Dilate versus constrict, right? Because adrenaline will constrict. Are they gonna have hypotension? Yeah, isn't that wonderful? How about bradycardia? Bradycardia potentially, because of the lack of stimulation of SA node. You see all the whys with the hormones. What is your biggest concern with Addison? And it's certainly an Addisonian crisis.
Cardiac collapse.
Done, end of story. Cardiac collapse. You may read vascular collapse. Cardiac compromise, it's all the same thing. Now, why do they have an Addisonian crisis? Because is the stress so overwhelming that the adrenal glands cannot keep up compensatorily? That's exactly what's happening. So you have a couple different things. You have a lack of ACTH. Could you have primary adrenal, malfunction? Yeah. And we could go into that pathology, but what I really want you to understand are what Addison looked like and how dangerous it is. Can you say that Addison's is in a state of adrenal insufficiency?
Yes.
What else causes that?
Stopping steroids.
You guys have learned some stuff. Abruptly stopping to take those the corticosteroids. Yep. Is it dangerous? So, did you just have a light bulb moment? You did! God, I love it when that happens. So, how would you treat that? Can you give us some fluids? Can you give us some IV push cortisol? Yeah? Are you gonna start pushing a little bit? Are you gonna, first of all, treat them symptomatically? How about giving some sugar, some dextrose? You bet. Can you give them an amp of D50 for that blood sugar of 20? Brain's dying at that point. Can you give them some IV fluids to crank up their blood pressure? And then you start doing, so you do that emergently, and then you can give them the hormones. Good. I can't find my liver question, but who do I need to go to for this? It's here. Because liver involves everything. We just found it, good time. It was under the Whipple, it was under the dumpings. Who would like to take this on? Because we're gonna talk, okay.
I missed my question, so.
Oh, I love it. That's so let's do it. So the premise to the question, of course, it's gonna be a select all that apply. And it's all those pathologies. I had to cram it into one question. And it's select all. So what are the potential complications of cirrhosis?
Hepatic encephalopathy.
Yes, good. Oh, she's talking about
Which is the buildup of ammonia.
Ooh.
And with that, to test for it, it's the
Asterixis. Yes.
Like this.
The hepatic flap.
Yeah, hepatic flap, yeah. I think it's asterisks, like these look like little asterisk marks, so.
Ooh, I might steal
Yeah.
that one.
And treatment is lactulose, because it follows the poop out.
Ooh, is that good? That's good, right? Okay, what else do you have?
Acute alcohol withdrawal syndrome.
Oh, yeah. And how do you guys know if they're withdrawing? Tremors. How about confusion, agitation? Do they start losing context? Yeah. And why do you wanna early recognize something like that? Yeah. Have you ever seen an acute alcohol withdrawal seizure?
Yes.
They are ugly. Those are some of the most cyanotic seizures I have ever seen. You have epilepsy and you have acute alcohol withdrawal seizure. Purple. And then you think, how do you oxygenate a person having a seizure? Can you hook on some nasal cannula? Yeah. It's probably easier than putting like a simple mask on them. Are they gonna breathe perfectly? No, but at least they're snorting in a little bit of O2. Okay.
Pam is gonna help that guy
Pam,
out.
Pam is going to help that. Pam is lorazepam, isn't that beautiful? See the way you're remembering these things? Is that from Nurse Mike? Did she say
No,
that?
that's just one of the girls, I think Jill.
Really?
Jill says the Pam's.
That is fantastic. No, Pam is here to help.
Yeah.
That is fantastic. Okay, what are your other
And there's portal hypertension.
Oh, which can lead to?
Esophageal virus,
Yes,
which leads to hemorrhage.
yes, yes. Very good, so let's stop there. So she said portal hypertension that can lead to bleeding esophageal varices. And she's right, she went to the conceptual side, which is hemorrhage, because that's what they're doing. So all this pressure from the liver, that hypertensive state, it causes varices to bust, not only the esophagus, but the stomach. Those ones in the stomach are bigger.
I was actually looking this up last night for like 2 hours, that's why.
Oh, good. No, it's good.
I know.
It's good.
So I didn't understand, was this like pressure from the liver, what is
Yeah,
that?
portal system.
So the portal, I looked at it.
The scarring
Okay,
causes pressures on the vessels in the liver.
okay.
It's almost like
But those vessels go to,
the portal, well, you have to study the portal system.
okay, I'll
Yeah,
look at
it
that.
goes, the portal system actually goes through the liver, and then you have the splenic blood flow to the lower third of the esophagus.
Okay, so that's like a picture of the stomach, and then like the liver will go over here.
Yeah,
That's a
yeah.
different, like,
It's, yeah, the portal,
Stuff.
that's what happens.
Okay.
So the cirrhosis, causes the tissues change in the liver.
Okay.
Causes that hypertension, hyperpressure on those vessels.
Yeah.
Hence why the TIPS procedure works. Is it last resort? Yes.
yeah.
And we're gonna go back to you because you're doing so good, but what is the TIPS procedure to take care of portal hypertension? Is it almost like a bypass? It's a stent. Is it a decompressor? It is. So does it, it's a stent that's put in there that will bypass a highly pressurized area, so then you have the blood flow going through a very low pressure vessel. Is that making sense, I hope? But anyway, the whole conceptual thing is to decrease pressure, that portal hypertension. Because the more portal hypertension you have, the more bleeding you have, would you all agree? Is there something you can give your patient for that portal hypertension? Can you give an antihypertensive? Which one? The beta blockers. Oh, darn it. I should have just learned it. So beta blockers, right? That's one thing you can do. Because what you're doing by giving those beta blockers is you're decreasing the pressure. Those vessels go like this, don't they? Speaking of beta blocker, it's like blocking adrenaline to those vessels, so they relax, they dilate. So now you have lower pressure in that splenic blood flow here. So it's gonna probably minimize, or at least slow down the bleeding of those varices. But then sometimes last resort, they can go in there with the TIPS procedure. And then let's talk about the bleeding varices. She went conceptually. Does that mean that you will be treating her? Yep. And how was that? First thing you give when your blood pressure starts to tank? Bolus of fluids. IV fluids, number one. If there's any one thing that you learn in this semester, IV fluids for hypertension, IV fluids for hypertension for in most cases. And then pressors if they need it. Now in this case, they're hemorrhaging. Did you already get your Titan screen for a couple minutes of packed red blood cells? Yes. I told the other class, the varices bleeds are some of the worst hemorrhagic bleeds you will ever see because you have the high retention from that liver dysfunction. So it's not only just a bleed from a cut or a laceration, you have a high pressure system right behind it, just pushing all this blood in there. And then you know what happens when they start bleeding in their stomach? Take a while, yes. They start to grow up. Because the stomach, it's the grossest thing. So be careful. When you know you have a variceal bleed, put your face shield on, get ready for a big explosion. Now, why do they throw up? Yeah, the pressure in the stomach will stimulate the emetic response. And when they start, that's the GI bleed. Give them an antiemetic, absolutely, and watch out when they start to go because they are that blood's gonna be flying everywhere. It's dangerous, so face shield, full face shield on that one. We're getting a little deeper because it's fun, it's kind of interesting, right? Doing really good. What are the surgeons, the GI doc gonna do for those varices? They can you put a tube in there? Spins doc in, yeah, a little more tube. And what's that likened to? A balloon? Angioplasty, right? It compresses those varices so the varices don't bleed. Or at least it, slows it. It's almost like a pressure linkage. They wear it for about 24 hours or something like that. But can they cauterize? Can they do cryo? So there's other procedures. But at least what we're doing is preventing them initially from dying from hyperventilation. That's what we're doing. And you're going to be treating a lot of this stuff. Are you going to draw an H&H? Because you have to know what H&H is before they order the blood. See how it goes? So are some of these blood transfusion orders metamerge? The answer is yeah. Metamerge means they can usually mix it up within an hour. It's not perfect, but we're bolusing them anyway, hemodynamically. You are doing great. What else are they going to be doing here? Oh, is there a medication you can give for bleeding some chill varices? Octreotide. That's a vasoconstrictor of those vessels right there. Right? So very specifically for bleeding esophageal varices, very good. What else do you have for us? Oh.
I saw ladies with ascites, it was so bad, because we are like that. They couldn't help her because they didn't have anybody to breastfeed. She had to go to another.
A student asked me in the other class, they said, is it hard to do 2 classes? I said, yeah, because I want to make sure you have the same information. Because sometimes we get creative and we sort of go in a different direction with each question and stuff. Fatty liver, no, but it may be on CMS. Cirrhosis, we just did that, right? Pancreatitis, we did that in depth.
So you wanted to go back to SIV?
I did?
Did you do it
Yes.
already?
Yes, I put a question mark even.
Yeah. Forgot what you had said.
You should tell you to come back to it.
Okay, let me see if I remember the answers, okay? So that's lupus. Is it autoimmune, true or false?
True.
Does it attack most organs, especially the kidneys? Are they going to take lifelong immunosuppressants?
Yes.
What type of, and is it a hypersensitivity 3 reaction?
Yes.
Do they have hyperglycemia?
Yes.
Secondary to what? Corticosteroids. You see? Critical thinking. I think those are the answers. to that question. Yeah, that was it. Did everybody get those? Yeah. Taking the corticosteroid. So, let's do it again. True or false? Is it an autoimmune disorder? Do they have to take lifelong immunosuppressant therapy?
True.
Yep. Do they, does the disease attack most organs?
Yes.
Or the, systemically the whole body, but it can also attack organs, right?
Yes.
Are they immunocompromised?
Yes.
Yes. And are they hyperglycemic? Yes. And I think that's pretty much it for lupus. It's cruel. Lupus is one of the worst ones. 37, what time did we get out, 45?
Yeah.
Okay. Yeah, I think we've done everything on the list. Let's go back to this. Yeah, we've done everything there. All right, I'm gonna erase it. Oh, sorry. Sometimes I'll sing into that mic. Maybe. All right, let's do a rapid fire quiz here at the end and see what you guys have. And this is going to be, let's do this, okay, and then I'll call on you. Okay, diabetes insipidus is lacking what? I saw the first hand, what is it? ADH. As a result, what are they gonna be doing all day long? Okay, I saw that one already, what is it? Peeing a lot, right? Okay, what does their serum osmolality look like? High, that's right. And then what does their urine look like? Low. Specific gravity too?
Yes.
Ooh, very good. Okay, SIADH. What's the problem with SIADH? Okay? Too much ADH. As a result, what are your clinical findings going to be? Okay? It is between you, I'll go Noreen on this one.
Edema, hyponatremia, hypertension.
Hypertension. Is hyponatremia scary? Yeah, because they can have seizures. So that one to me is the scariest one. And edema, hypertension, definitely. Can they have neurologic changes because of the hyponatremia, the seizures from the death or confusion? Very good. Okay, what does the serum osmolality look like in SIADH? It's low, so there's a hyponatremia again. Okay, what does the urine look like? High.
So
Oh.
it's the gravity.
Exactly, good. Now why? Why are we talking about diabetes insipidus?
No.
SIADH, sorry. Okay, in SIADH, why is it high in the urine, or higher?
Because it has a normal high concentration.
It has a high concentration, right, but why?
They have more time to concentrate.
Oh, good. And you know what she said? Have more time to concentrate the urine. That's what it should be saying. That's right. And because you have to tell the kidneys to concentrate the urine. Two things. Is it absolutely opposite with DI? Yes. So you guys individually know what you need to study, right? This is one of the things, I'm going to do some good hard prayers with this one right here. Because I think this class has the capability to do better than any class before. I'm hoping we can get into the 90s on this one. So really, really look at that. It's gonna be, yeah, it's gonna be on the CMS probably, and definitely you're gonna see those labs. Okay, are we done? Pretty much.